Hi, this is Dr. Shravani Dirbakala from the Johns Hopkins School of Medicine Pain Treatment Center. This presentation is on seroma formation after spinal cord stimulator implants. So what is a seroma? This is a surgical complication, generally seen 1 to 2 weeks postoperatively, and it presents with swelling and irritation at the IPG pocket. Serosanguinous fluid is building up at the wound. This is serum, liquefied fat, lymphatic fluid. It is not pus, CSF, or blood. It's clear to pale yellow colored, and it occurs in 0.9 to 5.8% of the cases that we do. So the clinical presentation, generally this is an afebrile patient with a swollen, tense, inflamed wound, and it can be quite painful due to stretching of the skin. This is just a picture here with your skin, your incision, and your seroma. So is this an emergency? So no, it's generally benign, but it may be very painful for the patient. It can become infectious, and it can delay wound healing. So it's certainly something that needs to be managed. Differential diagnosis for swelling around the IPG pocket. So seroma, hygroma, which for anyone who doesn't know is when CSF travels along the lead, it tracks down to the IPG pocket, generally after a wet tap, and accumulates there. Hematoma, and then infection at the site. So that generally presents with fevers, chills, and purulent drainage from the wound. Why does seroma form? Traumatic pocket creation can be the cause of seroma. So you have injury to tissues, blood vessels, lymphatics during the creation of the pocket, and then this leads to death of cells and accumulation of inflammatory fluid, which builds up. The other thing is excess dead space in the pocket. So if you make a pocket that is too large, that can lead to a seroma. And studies are unclear, really, about if electrocautery increases the risk over blunt dissection. Some say yes, some say no, so we're not entirely sure about that. The workup should include labs, so CBC, ESR, CRP. You want to rule out any kind of infection. And then imaging, so ultrasound, CAT scan. Here's a seroma on ultrasound. So you can see it's anechoic, it's compressible, it has clear boundaries, and there is no vascular flow here. Conservative treatment, most of them can be managed that way, so you want to monitor them. Most resolve in 2 to 3 weeks. They may occasionally calcify if you just monitor them, and the patient may feel small knots, but for the most part, that's tolerable. You can use an abdominal binder to create a counter pressure that will help the seroma to resolve more quickly. So what if it's painful and the patient really can't tolerate it? At that point, you can consider doing serial aspirations. Of course, you want to do this under fluoroscopy. That way you can see the spinal cord stimulator leads and avoid damaging them with your needle. You want to use sterile technique and then send whatever you aspirate for culture, sensitivity, and fluid analysis to make sure you don't have an infection, and also fluid analysis will make sure there isn't CSF there. So what if it is infected? What are you going to do? So you want to utilize IV antibiotics at this point, and the safest way to handle this would be to actually remove the entire device. The leads from the pulse generator are connected to the epidural space, so you wouldn't want that infection to track upwards into the epidural space. You want to irrigate thoroughly and then place a drain before closure. That drain can be removed in about 3 to 4 days generally. Here are my references. That concludes this presentation. Thank you.